So my name is Dr. Kevin Ewanchyna. Some of you have seen me before at the Lunch and Learns here, but some may be new to our Lunch and Learns, so I wanted to make sure I introduced you myself and gave you a little bit about my background. I'm a family physician by training. I love the practice of medicine. I still see patients a day a week in urgent care, but over the last 19 years of being in Samaritan Health Services, the past 10 years have been in administration. The first 5 years or so were overseeing the primary care practices for Samaritan Health Services. And then 5 years ago, I went into the health plan side as there was no full-time physician presence there for a while. And this has been really eye-opening to me to see how we can structure health plan benefits to truly impact and change the health outcomes of people in the community. And it is something that doctors have zero training in. We know how to diagnose and treat, but we have zero knowledge in terms of what is a benefit for a health plan and how a person uses the benefit. And I myself, with my own insurance, Samaritan Choice, I get confused at times as to what is included in my health plan benefit and what is not. So if you ever have those senses of frustration and have questions that come up, our customer service agency within Samaritan Health Plans is freely there to help guide you through these questions that you have about how to best utilize your benefit. I have three kids. One is, our oldest is a 20-year-old son who spent a couple of years at Oregon State University, go Beefs. But now he is shifting and he's actually going through the process now of enrolling as a Marine. And so I will be the proud father of a Marine for the next few years, and then he wants to go back and do a degree in criminal justice and be a community police officer. I have two other kids. They're seniors in high school in Crescent Valley in Corvallis. And my daughter is going to go to U of O. And then she wants to be a pediatrician or a neonatologist after that. So I'm going to have to invest in one of those split shirts with one side of a beaver and one side of a duck. Because come Civil War time, I'm going to have to, live in this house that's divided. And I have a third son that is also a senior in high school. They're twins. And he's going to be looking at doing something with computer game design up in Washington. So it'll be good to have all of them at least a little close by. We'll see where my Marine son eventually goes to, but I'll keep you posted at these Lunch and Learns. I have a wonderful wife who is very supportive of everything that I've ever wanted to do in medicine. She is a chef and she teaches part-time at Lynn Benton Community College in the Culinary Arts Department, but she has her own chef service where she goes to people's homes to do their dinners and their meals and dinner parties for them, and she is amazing. I wouldn't be where I am today without the support of her. So that's me in a nutshell. If you hear a little bit of an old Canadian dialect still coming through as I'm talking, I was born and raised in Saskatchewan, and 19 years ago, my wife and I needed to leave the prairie snow in Saskatchewan and try to move more closer to the West Coast, where I don't have to shovel rain, but I can drive to the snow when I want it and then drive away from it. And so we've been really blessed living here in Western Oregon. And as you can attest to the day we're having today, what a wonderful fall day this is. So I could only put it in an order for a few more days like this in like December, January, February, I think we'd be set. So today we're going to be talking about sleep. And not a lot is understood about sleep. We know we need it. We know how we feel when we don't get enough of it, but it's still, in terms of a science of what we understand about it, it's still not as much well understood as a lot of other health conditions. So I'm going to give you some up-to-date examples on what we know today about sleep. And then we're going to hear later on, well, what are some medications or some options for improvement in sleep? And I'm going to touch on a dangerous syndrome called sleep apnea that many of us may not know that we have, and we'll walk through a screening tool that you can fill out and then take to your family doctor for help with screening out of sleep apnea if you screen positive on this questionnaire. So the first part is how age impacts sleep. And we know that as we keep getting older, that there's a lot of things that happen with our sleep. It gets more disrupted, and there's some science behind the why this occurs. Sometimes it's just due to pure aging, but as well it may be due to health conditions that we have or medications that we're taking that may sometimes interrupt that sleep. So some of the questions we hope to answer today is, how does sleep change as we age? And I've heard about this, but do we really need less sleep? I get less sleep, but do I need less sleep as we get older? Can I as a person experience more sleep problems or have a sleep disorder as I get older? So we'll talk about some of the sleep disorders. And as we age, how does sleep affect our overall health, medical conditions, general well-being? But most importantly, what can I do to try to get as good sleep as possible? So we know that sleep is very essential to our functioning as a human being. It's key to our health and our performance and quality of life. And it's also key to safety. We know when we get less sleep, we're more prone to accidents, and that's been shown over and over again in our studies. But it's as essential a component as good nutrition. We talk about all the good things we should eat to have a healthy body. We talk about good exercise, but we have to recognize that good sleep is equally as important as exercise and good nutrition. And it's essential to perform both thinking or cognitive tasks and physical tasks. We know when we don't have a good sleep one night that the next night we may feel a little more foggy, or we may not feel like we have the energy, the physical energy to do the things we normally would be able to do. So it really does impact us. Our internal clock, our circadian rhythm, is what we call our internal clock in our brain. And it sits right in the brain and regulates when we feel sleepy, when we feel alert. And it works also in tandem with the amount of light cycle that we get through the day and the amount of darkness that we get through the day. And you'll see on the diagram, the hypothalamus is our overall regulator. That's the one that shows up in white on the diagram. That's our hypothalamus. But there's a part that goes right from our retina, our eye, and it's the retino-hypothalamic tract. This is the amount of darkness and light that our eyes themselves will get. And it sends that signal right to the hypothalamus. So if we live in areas, Alaska for example, where we're closer to the Arctic Circle, and we're going to have more hours of darkness through wintertime and more hours of light in summertime, it can start to affect our circadian rhythm, our biological clock. So think of time periods where we hear this as we're getting closer to daylight savings time, where people start to feel more sluggish. They feel that their biological clock is telling them they almost want to hibernate. That's because of this amount of darkness, that we're getting more dark in our hours versus light. The circadian rhythm also affects our body temperature and our hormones. So our hormones will change dependent on how much light we get in a day and how much dark we get in a day. And our body temperature will also fluctuate with light and dark. This is the sleep cycle in adults, and there's 4 stages in sleep, but the most important part of the sleep cycle are the parts in blue, REM sleep. That stands for rapid eye movement. And it's a kind of a funny description because our eyes are fluttering a lot during rapid eye movement, but the rest of our body is completely still. And our REM sleep, or rapid eye movement sleep, even though our eyes are fluttering a lot, this type of sleep is very restorative. We need this amount of sleep. And if you only stay in stages 1, 2, or 3 and you never get into the REM sleep cycles, your body, our bodies, do not restore as much. And there are certain medications that sometimes can interfere with REM sleep. And they did a study with a bunch of college students many years ago, a couple decades ago. And they went, and our REM sleep cycles happen approximately every 90 minutes. And they went and woke up these college students in about an hour of a sleep. So they prevented them from ever getting into REM sleep cycle. And they did this for just one night. And then they studied their effects afterwards. They were much more sluggish. They started to have body pain where they didn't have body pain before. They started to have headaches where they didn't have headaches before. And again, it's just that sign that we need REM sleep to restore our body, both cognitively, mentally, and physically. And we don't know, REM sleep is very poorly understood of all the sleep cycles. We know we need it, we just don't know what it does to our brain during that restorative part. We also know that we get less, we have shorter amounts of REM sleep as we age, and that impacts us with our ability to think and remember. When we look at babies in infancy, and then in mid-age, and then in older age, you'll see that in infancy, the amount that is spent awake in babies is about 1/3 of our day. 2/3 of infants sleep. And it's equally split between REM sleep and non-REM sleep. So think of a baby right now. You're learning so much about the world. You're learning to talk, to eat, to interact, maintain facial expressions, learn about the world around you. There's so much that is coming into the brain. It's not surprising that half of the sleep is spent in REM sleep to try to process all of that activity that the brain is undergoing. Then we get to mid-age, and we have 2/3 of the day that is spent awake. And we have, of our sleep cycles, more of our sleep is spent in REM sleep, or non-REM sleep, and less of it is spent in REM sleep. And then look what happens as we get into older age. We're still spending the same amount of waking time, but we're spending even more time in non-REM sleep, less time in REM sleep, and then even in our non-REM sleep, you'll see on the very far right graph where there's little arrows of orange that is breaking up the non-REM sleep. That means that we're having more awake cycles throughout the night compared to that time period where you used to sleep all the way through the night. What is one of the major things that interrupts our non-REM sleep and gets us awake as we age? Going to the bathroom. Affects both men and women. Men because of the prostate, and as the prostate grows, we find that we have that urgency sensation maybe a couple of times through the night, maybe more, and it really breaks up our sleep cycles. Women also have that issue with urinary issues, but it's more of maybe the urinary incontinence, or the bladder just can't hold as much urine as it once could. And we can usually blame childhood and bearing children that gives that problem with women. Our health and environment also affect our sleep. Hormonal changes, physiological changes, and environmental conditions. Hormonal changes. What happens to women in the decade of our 40s to 50s and onwards? Menopause. What happens with menopause? Hot flashes. Do hot flashes interrupt sleep? Absolutely. And I'm seeing a lot of nodding heads. But physiological changes as well. And these changes that are happening as our organ systems start to change. And that can disrupt our sleep as well. And we have a slide to talk a little bit more about these different changes. But our environment, our light in our surroundings, in our bedroom, the amount of noise that we're exposed to, and definitely our temperature. I put temperature in there because the studies have shown over and over again, if you want one of the better sleeps, try to have your room as cool as possible. As we get overheated, we toss the covers on and off, and it disrupts our sleep. And cool sleeping conditions actually give a better sleep overall. As we age as well, we become a little less efficient with our amount of sleep. And you'll see on the far left graph, age is at the bottom, so age 10 years, going through the decades, all the way to the 70s, that our sleep efficiency, meaning our percentage of time spent in bed with sleeping, not just spent in bed and waiting for sleep to occur, but how much of our time is actually spent sleeping while we're in bed. And it does become less efficient over time. The colors on the graph are a little bit erroneous. So you'll see men is still the blue squares up on the graph, but women are the orange circles in the graphs. And again, highlighting to women what happens in our decades of our 40s and our 50s, menopause. And that's showing that the sleep efficiency is definitely decreased in those decades. As we get older as well, we will see that in our decades of 55 to 64, 65 to 74, and then 75 to 84, you'll see the incidence of insomnia or having difficulty falling asleep, staying asleep. It increases over the decades. And our snoring actually is at its peak in our decade of the 55 to 64. It doesn't mean that it goes away, but we see less problems with snoring and other problems with restless leg syndrome that actually increases over the decades. I found that very surprising. The thing to point out for this slide is that snoring and sleep apnea together are pretty well paired. We see that it's higher in ages 55 to 64. It doesn't go away, but it gets slightly better in 65, 74, and 75 to 84. And we have a slide talking specifically more about the link between snoring and sleep apnea. And the sleep apnea is a medical condition. But insomnia, let's talk a little bit about that and that definition. But it's a perception. Everybody perceives something differently, so it's really your perception of your sleep. It's a complaint of inadequate or poor sleep, poor quality. So it could be difficulty falling asleep or a lot of frequent awakenings for whatever reason. It could be waking too early, having difficulty falling back to sleep. I sometimes have this where I'll wake up in the middle of the night and then an idea pops into your brain and you're ruminating on this idea for a while, and an hour goes by and you still haven't fallen asleep. Or a sense of waking up unrefreshed. But it's a pretty high prevalent condition and it affects as much as 48% of us as we age. We definitely see a lot of consequences the next day if we look at how we feel the day after a poor sleep night or a good sleep night. We can really tell that difference. But we do know that there's a lot of effective treatments, and we'll go through them. Healthy sleep habits, that is number one, as well as behavioral therapy. And later on in the program, Patricia Sheffield is going to guide us through some behavioral therapies for meditation that can ready our brains and our bodies for that sleep process. There's also prescriptions that can help us with sleep, and that's going to be the second presentation for today, and then other therapies as well. But let's talk about snoring. By raise of hands, who knows that they snore or who has heard their spouse tell them that they snore? All right, and that's about right from what we see in the percentage of how frequent snoring is. But snoring, of course, is the noise, but it happens because it's a partial blockage of the airway that causes some abnormal breathing and sleep disruptions. And over 90 million people have experienced snoring at one point in time or another, but 37 million people experience it on a very regular basis where it's every single night that they're doing snoring. But snoring, you may have some people that snore for a couple of times in their lifetime and then not at all, and it could have been due to a medical condition that they were resolving at that time. Males snore more than females, and people that are more at risk for snoring are those that are overweight or have a large neck size, and these are the people that are more at risk to become snorers, and the risk of these people is also high for the condition sleep apnea. Loud snoring does not mean sleep apnea, but loud snoring can be associated with sleep apnea. And so you may be sleeping beside, most people that have sleep apnea that has not been diagnosed yet, they don't know it. But their spouses may know that they have sleep apnea. And their spouses may hear them snoring like, and then all of a sudden, there's no breathing for a while, and the spouse is getting ready to shake them because they are not breathing, and then all of a sudden, and then starts breathing again. And that can be a condition that can be linked with sleep apnea, and most of the time the diagnosis comes from the spouse. So what is sleep apnea? It is a potentially serious sleep disorder in which the breathing repeatedly stops and starts. And what happens over time of this stopping and starting, it actually puts a strain on the heart. And this is what we understand about sleep apnea today and why we treat it. It's not to treat the snoring, it's to treat the effect on the heart itself. And we're going to talk about this effect on the heart and the other conditions that it is linked to. But it increases as we age. It affects about 4% and 2% of middle-aged men and women. So 4% of men, middle-aged, and 2% of women. And it's close to 27% of older men in the geriatric age and 19% of women. So you can see from middle age to older age how much this jumps up quite dramatically. It's characterized by this pause or this gap in the breathing, and it's because the back of the throat, see on the diagram there, that the tongue is compressing the soft palate and it's actually closing off the breathing. So you're not getting air going in or out anymore. And this is why it puts the strain on the heart itself, is that complete obstruction of breathing. Signs and symptoms of sleep apnea: loud, regular snoring, the large neck size, obesity, but it can be associated with other major medical conditions as well. And one of the main treatments today is CPAP. And CPAP stands for continuous positive airway pressure. So it's with the mask that you see up there, and it's this continuous pressure of air that's going into the nose and the mouth to keep everything flowing so that things don't close down and obstruct. It comes with it a noise, and people then can have sleep issues just basically sometimes due to that noise of the CPAP machine. They are loud and cumbersome. You have to take them when you travel. People going through airport security have different lines, but it's one of the only treatments right now that we have for sleep apnea. They've tried to look at surgery for sleep apnea too, see if they can either do away with some of the redundant tissue that falls backward of the soft palate. And the outcomes with surgery, with heat therapy at that part of the throat and the soft palate really haven't given us great outcomes. The best outcome is still with the CPAP machine. And you can have testing for sleep apnea at the Samaritan sleep labs that are in Albany. And your primary care doctors will know about this sleep lab. And we contract with sleep medicine physicians that look at how people are doing and measure your oxygen levels throughout your sleep. And they'll measure how much of the time you're going through REM sleep. So it's a service that's out there that many people may not be aware of. But please talk to your primary care doctor if you might have some symptoms of sleep apnea that you're not aware of, or that your spouse is telling you that they see that you're having. And we'll go through the stop-bang questionnaire a little bit later. These are all the things that can be related to sleep apnea. It doesn't mean the sleep apnea causes it, but it may be in association with it. So for men, sleep apnea is related to impotence. Maybe because of oxygen. We need oxygen to get erections. And if we're not getting enough oxygen throughout the nighttime because of sleep apnea, is it actually giving problems then with oxygen levels through the day as well? Also, this strain on the heart. We need good heart functioning and good blood pressure to maintain and achieve erections. And so there may be a relationship with sleep apnea and impotence. Definitely we know there's a link with hypertension. I was talking about this strain that the heart is being put on, and untreated sleep apnea, the heart grows and grows and grows in size, and this leads to high blood pressure or hypertension. It's linked with obesity, and obesity is sort of a part of the cause of sleep apnea. Studies have shown if we do lose 10% of our excess weight, we might be able to improve our outcomes with sleep apnea. We know that people that have sleep apnea are very drowsy, and these are the people that sometimes could fall asleep at the traffic sign, or they fall asleep watching the evening news within 3 minutes, and they're always daytime drowsiness or having headaches in the daytime and they don't know why. These are all underlying symptoms of sleep apnea. Definitely fatigue. Diabetes is not a cause of sleep apnea, but what happens if we're more overweight or obese? We're more linked to have diabetes, and this is why we see this link with sleep apnea. But people that have sleep apnea are more prone to have car accidents, job impairment, more prone to have an arrhythmia. As the heart enlarges because of this strain the sleep apnea is putting on it, an arrhythmia like atrial fibrillation is more common. And this is where the heart, because of its enlarging, the electrical signals are getting a little changed, and you get this fibrillation pattern. You may not feel it, but the one thing you may feel is an irregular heartbeat that keeps going on, so be on the lookout for that. Sleep apnea is linked with an increased risk for heart disease, and this is why we treat it with CPAP in the first place. I talked about headache, not getting enough oxygen levels, but it's also linked to stroke, an increased risk of stroke. There can be also increased blood pressure within the lung tissue. So picture if you're not breathing and your brain wants you to breathe, but you're completely closed up here at the neck, you're obstructed. This is putting more of a pressure on your lungs as well. And so we see that the blood pressure inside the lungs of these little capillaries starts to increase. And we know as well that sleep apnea is linked with memory loss and possibly earlier rates of dementia. Not Alzheimer's dementia, but dementia because of lack of blood flow, lack of oxygen going to the brain. Almost like the dementia that you can get with what we call mini strokes. And people may not feel the strokes in their body, but you do an MRI or a head CT, and you see these little tiny mini strokes that people have been having over time. Question?
Is there a difference between sleeping on your back or on your side?
Yes, the question was, is there a difference between sleeping on your back and sleeping on your side? Yes, people have more obstruction symptoms usually when they're back sleepers, and that's because gravity and our floppy tissue, it allows gravity to push even further back. So if you're a snorer, you may have your spouse that kind of tries to get you on your side to sleep because you usually snore less or have less problems with sleep apnea. I've heard from people that use the CPAP though, that it's difficult to sleep on your side, that you get your best outcome if you truly have sleep apnea and you're using a CPAP machine, that you probably get better use of your CPAP machine if you're on your back, because then it's allowing that air to go back and forth. Very good question. But the sleep apnea cycle, you have the snoring, the airway collapses, the breathing stops, you get a disrupted sleep, and it keeps on going throughout the whole night. And unless we break that cycle with something like CPAP or other things to maybe lose weight, that is one of the treatments for sleep apnea, we have this cycle of continuing to have this increased strain and pressure on your heart and on your lungs, and then that affects the rest of the body. We talked here about how the CPAP works, and you can see that on the diagram now where you get this steady stream of air that's going all the way through the nose and through the oral cavity down into the trachea and below, and it basically stops that collapsing of the back of the throat. It does take time to iron out the wrinkles in CPAP therapy, so if you're a new user of it and you just hate that feeling of the mask and you want to throw it off, I would just say give it time. And one of the strategies can be start using it just for a couple of hours to get yourself used to it. And then as each day goes by, try to increase it by another hour and another hour. So if you try to keep it on for the whole night and you're a brand new user, you're probably going to get very frustrated and you'll just throw the machine against the wall. So start slow and move upwards. But know that this is a therapy, and there's a reason behind this therapy. It's meant to decrease that strain on your heart. Question?
So people who have thrown the mask and are having problems with their hearts now, it's too late.
Yeah, so the question was people that are throwing their masks and already having problems with their heart, that this may be too late. What this does is it stops the accelerated rate of damage to the heart. So there can be a certain amount of overgrowing of the size of the heart and the blood pressure, but it does start to normalize it. And we've actually seen remodeling of the heart. So it's not that we would ever get us back to our baseline of where we were, but it's helped stop that increased growth of the heart, and it starts to normalize it somewhat. So there's still benefit in people that have had sleep apnea untreated for years to start to have treatment.
If they get on the CPAP.
If they get on the CPAP, yep. That's still the number one treatment, as frustrating as it can be, yeah. Other sleep issues that people may be having. Restless leg syndrome. Who has that in the audience? I do. Those that have raised their hands, have you ever talked to your family if they have it as well? Usually you can see this running in a little bit of clusters in family members. I have it, my dad has it, my paternal grandmother have it, 3 to 4 aunts and uncles on my dad's side of the family have it, and one of my sons has this. And unless you start to ask the question, you may not see this kind of genetic predisposition to restless legs. But it's a neurological movement disorder. Much like Parkinson's disease is a neurological movement disorder. So it doesn't mean that they're linked, but they're in the same families where they're movement disorders, but it starts from the brain. And it's this involuntary urge to move due to an unpleasant feeling in the legs. And I've had family members ask me how to describe it. And it's like a creepy, crawly sensation in the bottom of my feet. Sometimes I've even had it in my hands, but one side of my body for some reason. My left side more frequently than my right side. And I just have to either kick or move, and it keeps happening repeatedly throughout the night. It's sometimes the jerking of legs and arms during sleep. Now, many people will have these initial, you're just drifting off to sleep, and then all of a sudden you'll sort of have a jerk. That's not restless leg syndrome. That happens with all of us. But it's the jerking of the legs and arms that are repeated over and over that are preventing people from having good quality sleep that is part of the restless leg syndrome. It does increase with age, and there are some medications that can help treat it. Also, healthy lifestyle and sleep hygiene can help with this as well. And this is one condition where drinking alcohol can actually make it worse rather than making some sleep issues better. So this really has to be watched with your intake of alcohol, because you can get worse and worse restless leg syndrome with it. Other conditions, though, that we see just increasing as we age, we see that high blood pressure increases as we age, and heart disease does as well. Also, along with congestive heart failure, we see that happen more frequently as we get older, and stroke, menopause, cancer, and gastrointestinal disorders. All these things can disrupt sleep and have a negative impact on our sleep as well. So the more that we can treat these chronic conditions that are listed, we can try to improve our sleep quality as well. The GI disorders, constipation, irritable bowel syndrome, not feeling that we're moving our bowels as well, gas, bloating, reflux disease. Reflux happens more frequently at nighttime, and that can disrupt our sleep as well. Other things that increase, though, with age and that we see associated with sleep problems, Alzheimer's disease. Alzheimer's patients that have sundowners have very poor quality sleep. Parkinson's, poor quality sleep, and it's often because of the movements. Depression. When we are depressed, we may be sleeping more or we may be sleeping less, but it's definitely part of the syndrome of sleep disorder. Arthritis is linked. As our joints have more wear and tear, whether it's osteoarthritis, which is wear and tear arthritis, or rheumatoid arthritis, which is because of an autoimmune disorder. When our joints hurt more, we have more pain and we have less quality of sleep. But let's talk about alcohol. Caffeine, nicotine impacts on sleep. All of these things can impact. Alcohol, we feel sometimes if we have a drink of wine and then go to bed, we may feel a little bit more relaxed. But what we've seen in the studies is the more frequent alcohol that we use every single night, we may fall asleep faster, but usually 2 to 4 hours afterwards, we sort of have these awakening spells where we're sitting there awake for an hour or two. So it starts to disrupt our REM sleep, actually. Caffeine and nicotine definitely do this too. I remember in college in my 20s, I could go out for coffee with friends at midnight and then go back to sleep and have no problems at all. And now I can't have caffeine anytime after 4:30 p.m. in the afternoon because it just stays with me. It must do something to my brain that I just can't tolerate that amount of caffeine like I once could. And then nicotine, it speeds up the heart rate and it increases our receptors. And people that have a cigarette right before bed, even though in sometimes nicotine can be a little bit calming, especially if we're feeling anxious, but it can disrupt our sleep. So kind of watch those three elements if you're having some issues with sleep. But practical tips for good sleep, we want a regular schedule with consistent bed and wake times, and that's inclusive of the weekends. So for those that are still working, we have our usual routine, getting up to go to work, but what do we do sometimes on weekends? We might sleep in a little bit. If you're not having problems with sleep, then I wouldn't say you need to change anything. But if you are having problems with sleep, the studies have shown trying to go to bed the exact same night on weekends and weekdays and trying to wake up at the exact same time on weekdays and weekends help improve your sleep quality. But maintaining a relaxing bedtime routine, one of the biggest problems now that we have is watching TV, being on our computer or our smartphone. And it's because the TVs have changed. It's the LCD or the LED, which is the same thing as our computer monitors and the same things as our smartphone screens. But it emits what's called a blue light. And this blue light is stimulating to our cognitive centers of our brain. So you may have found there are times when you're on the computer late at night, reading the news, whatever you're doing, and then you want to try to go to sleep. Your brain is still kind of thinking a little bit because of that blue light that it's received from the monitor. So now they're recommending that we should be shutting off and having no screen time for anywhere from 2 to 3 hours before we actually want to try to fall asleep. And this is one of those bedtime routines that we should be looking at, implementing if we have sleep issues. And then a sleep promoting environment that is quiet, dark, and I already talked about this, but preferably cool. We sleep better in a cool environment. Limit fluids. Don't eat too much close to bedtime. The fluids and eating too much close to bedtime is more because of heartburn and acid reflux. We get that more frequently as we age, and then you're up all the time, sitting upright. It's impacting your sleep. But avoiding the caffeine, nicotine, alcohol. And if you do exercise, try to look at your time frame that you're doing exercise and limit it at least 3 hours before bedtime. Limit your time in bed as well. If you're having problems in sleep, they say one of the better things is don't just stay laying there tossing and turning. Don't keep looking at the clock. That's going to do you in because then you'll say, oh, another half hour has passed, another hour has passed, and I'm still not sleeping. Get yourself up, get yourself in a darker room that maybe has a small light, and sit upright in the chair. You can do even some reading of a book rather than a screen. But that strategy, getting you out of your bed and the tossing and turning and getting to another place where you can just be still for a while or practice some meditation, then going back into the bed and trying to get back to sleep. If you're having problems with sleeping, keeping a sleep diary to try to identify your habits and your patterns. And then the sleep specialist, which we have within Samaritan Health Services. Talk to your primary care doctor about that. So in summary, because I think we're right at the point where we're almost at a break, as we age, we have less deep sleep and a more lighter sleep. That's just common in us as we age. We also have difficulty maintaining sleep, and the sleep is less efficient than it once was. Look at that graph when we were a baby, and then mid-age, then older age, and you'll see the amount of time that we spend sleeping changes. The amount of time we spend in REM sleep changes. Our internal biological clock shifts to an earlier bed and wake time. So you know we always hear about those jokes, people that are the snowbirds and going for their dinner at 4 p.m. instead of 6 p.m. or 7 p.m. and we kind of make jokes about that. There's actually truth behind it because people are going to sleep earlier at night. Rather than going to sleep at 11 o'clock, you may be going to sleep at 8 o'clock or 8:30. So in order to prep for sleep, you're having earlier meal times, but you're waking up earlier in the morning as well. We know that older people experience a higher prevalence of medical conditions, we talked about that, and a higher prevalence of sleep disorders. Our tendency to stay in bed longer will result in a worse sleep. So we're staying there, but we're not sleeping, and we're tossing and turning, and we're thinking, well, if I stay in bed as long as I can, I'm bound to get some better sleep. But it's actually less efficient sleep. So when your biological clock tells you it's time to wake up and the day is starting, get yourself up. Don't stay laying there thinking you can get a few more hours, because you're probably not going to. More likely to take naps to meet your sleep need. But this can actually work against you in the long run, because when it comes time to evening and you want to try to fall asleep, your nap that you had in the afternoon sort of prevented you, because you're not getting really extra quotas of hours in your 24 hours to have more sleep. You sort of have a sleep quota. So you want to make sure you're getting your sleep quota through the nighttime when it's dark and when it's cool as much as possible. And the naps can start to undo you. Now, people that might have a 30-minute cat nap, those can actually be pretty beneficial. But if you're looking at having a 2 to 4 hour nap, that's going to start to work against you for your nighttime sleep quality. Sleep, we want to enjoy life, function well, and our overall quality of life is affected. So we want to adopt healthy sleep practices. We want to talk with your doctor about sleep and see a sleep specialist if you experience any of the chronic problems that we talked about. And for further reference, these slides were taken from the sleepfoundation.org, and that has a lot of other helpful tips that you can look at for sleeping itself. Very quickly before the break, if you look at the page that has updated stop bang questionnaire, this questionnaire was developed by the sleep medicine specialist to help screen out for sleep apnea. So just doing a yes or no question as you go through: do you snore loudly, so loud enough to be heard through closed doors, or your bed partner elbows you all the time because you're snoring in sleep? Or do you often feel tired, fatigued, sleepy during the daytime? Has anybody observed you stop breathing, or that choking, gasping sound that I just made for you earlier? Has anybody heard you have that through sleep? Do you have, or are you being treated for high blood pressure or hypertension? Do you have a BMI more than 35 kilograms per meter squared? And this is what the doctor checks with your height and your weight together. That's what a BMI is. And a BMI over 35 is more associated with sleep apnea. If you're older than 50 years of age, that's a risk factor for sleep apnea. And for men, if your shirt collar measuring at your Adam's apple is 17 or higher, that's a risk factor for sleep apnea. For women, if it's 16 inches or larger, that's a risk factor. And then men are more frequently to have sleep apnea. If you turn the next page after you've done that scoring, you'll see that if you answered yes to 0 or 2 questions, you're at low risk of sleep apnea. But if you answered yes to 3 to 4 of the questions, you're at intermediate risk. And you're at high risk if you answered 5 to 8 of the questions, or you answered yes to 2 or more of the stop questions. So the stop questions, if you look back again, you'll see it stop bang if you look at the capital letters all the way down the middle of the front part of the page. Snoring, tired, observed, pressure. That's your stop questionnaires. If you had 2 of those 4 and you're a male, you're at high risk. If you had 2 or more of the stop questions and you have a high BMI, you're at high risk. And if you answered 2 or more of the stop questions and your neck size is 17 or higher, you're at high risk. So I would say if any of you scored high today and you're unsure what to do next, I'm going to be staying afterwards. You can come and ask me questions, but I would want you to get a visit with your primary care doctor, who is also aware of this stop bang questionnaire. And you should get set up for a sleep study at the sleep lab to see if you're at risk of obstructive sleep apnea.